My name is Dr. Mark Socinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm also a thoracic medical oncologist and a member of our thoracic oncology program at the Advent Health Cancer Institute. The question we'll be addressing is the definition of oligoprogressive disease, particularly in the context of EGFR mutation positive disease. It became an issue several years ago when we started to routinely test for EGFR mutations. And we had a number of trials, at least 7 or 8 of them, that randomized EGFR mutation positive patients to a TKI. First, second, or third generation TKI versus chemo, and the TKI won in all of those trials. And so using a TKI became the standard of care. There is a subset of those patients treated with an EGFR TKI that have a great response. You know, they have metastatic disease, bilateral lung nodules, maybe other bony sites, liver mets, these sorts of things. All of these respond. And then as you're following patients, you know, a year to 18 months later, all the disease seems to be controlled, but there is a single site that's progressing, or 2 sites. And often this was in the brain. And so this syndrome of clinically seeing, 98% of the disease is controlled with a once-a-day pill, and you have a single site or 2 or maybe 3 in which you would consider using local modalities, either radiation most commonly, targeted radiation usually, or sometimes surgical resection to deal with the one site. Presumably there was a molecular mechanism at that site that was responsible for the resistance to the TKI, but it wasn't very gratifying to discontinue the TKI when 98% of the disease seemed to be controlled very well. And so we would tolerate this oligoprogression, control it with local regional therapies. And most commonly, initially, this was in the brain. And remember, our first, second generation EGFR TKIs have less than optimal CNS penetration and CNS activity. Our third generation drug, osimertinib, is much better in that regard. So the oligoprogression in the brain has become somewhat less common, but still obviously can occur. But the same paradigm would apply to a solitary lung lesion. And over the years, you know, I've radiated or SBRT'd a number of solitary lung nodules that were growing in the context of disease response every place else, bone mets, liver mets, these sorts of things. So it became, really the EGFR TKI story kind of changed our approach to managing disease progression, because we didn't want, and patients often didn't want, to give up on a oral therapy that was generally well tolerated, certainly very convenient, and was controlling the vast majority of their disease. And rather than give up and go to chemotherapy, we treated the 1 or 2 or 3 sites of disease with local treatment. And the literature is full of several reports that kind of report this, PFS number 1 and PFS number 2, where you can get greater mileage from the TKI in controlling disease before you have to move on to other options. So it became commonplace. And now, I think, interestingly, we have adopted this paradigm for certainly all of the other oncogenic drivers. And I've also adopted it for my populations of patients that are getting maintenance immunotherapy. It's also fairly not uncommon. I don't know if it's common, but patients on maintenance immunotherapy that are doing very well, and they have like a single site of disease progression. I'll often employ my friendly neighborhood radiation oncologist to radiate that site, in hoping that in the setting of immunotherapy, that whatever's going on there, the tumor's not, the patient's immune system is not recognizing that particular site. If you can, maybe release some neoantigens with radiation therapy, you'll have induce an immune response in that setting and have better control. That's certainly my way of justifying it. I don't know that we have clear evidence that that actually happens, but certainly is not an untenable hypothesis for expanding that sort of approach in patients that are on immunotherapy maintenance strategies.